Hello, and thank you for joining this OncLive peer exchange titled Therapeutic Sequencing Strategies for Advanced Kidney Cancer. Outcomes for patients with advanced renal cell carcinoma have been significantly improved by the availability of molecularly targeted therapies and now immune oncology-based regimens. However, proper selection of appropriate therapy and management of toxicities remain challenging for oncologists, particularly with availability of exciting new therapies and new combinations. Moreover, high-risk localized disease represents an ongoing challenge with high recurrence rates and poor survival after nephrectomy. In this OncLive peer exchange, I'm joined by a panel of leaders in the field. We'll be discussing new data from the GU ASCO 2018 meeting, and we'll discuss how and when to use available therapies based on new data. I'm Dr. Daniel George, Director of GU Oncology at the Duke Cancer Institute in Durham, North Carolina. Participating today on our panel are Dr. Neeraj Agarwal, Director of Genitourinary Oncology Program at the Huntsman Cancer Institute in Salt Lake City, Utah, and Dr. Robert Alter, Co-Division Chief and Medical Oncologist and Hematologist from the Division of GU Oncology at the John Theurer Cancer Center at Hackensack University Medical Center in Hackensack, New Jersey, and Dr. Bradley McGregor, an instructor in medicine at the Harvard Medical School and a clinical director of the Lang Center of Genitourinary Oncology at the Dana-Farber Cancer Institute in Boston, Massachusetts. And finally, Dr. Nicholas Vogelsang, Vice Chair of SWOG GU Committee and Professor at the University of Nevada Medical School, and Associate Chair of Genitourinary Committee for the U.S. Oncology Research and Medical Oncologist at Comprehensive Cancer Centers of Nevada in Las Vegas, Nevada. Thank you so much for joining us. So let's begin. Neeraj, can we start with you? Can you outline for us, particularly for patients with localized kidney cancer after nephrectomy, who's at risk for disease recurrence?
I think I'll mention the patients at the highest risk of recurrence. And those, in my view, are those who have what we call as T3 disease, kidney tumor invading the major veins, such as renal vein, or beyond the kidney tissue, or kidney cancer involving the local regional lymph nodes. So I think those are the patients at high risk of recurrence.
Okay. And that's roughly what percentage of patients do you think with kidney cancer, localized kidney cancer?
In my estimate, close to 1/3 of kidney cancer patients.
So a subset of kidney cancer patients have these high-risk features that we know are at risk for recurrence. And recurrence risk 50%, 60% over 5 years? What do you think that number is?
Yeah, I think pretty close.
Okay.
Yeah.
Okay. So Bob, now there's been a number of adjuvant studies over the last 10 years that have looked at this, and now recently there's been a new approval for sunitinib for treatment of adjuvant renal cell carcinoma with high-risk features. Tell us a little bit about the data that's kind of led to this approval and some of the other studies that are out there reported in this space.
Thanks, Dan. So there was the STRAT clinical trial that looked at patients with locally regional clear cell renal cell carcinoma. They looked at 615 patients in a 1-to-1 randomization receiving sunitinib at 50 milligrams daily, 28 days on, 14 days off of the 4-2 regimen compared to placebo. Patients were taken for 1 year, and the medications were continued until intolerability, patient withdrawal, disease progression. The data that was presented really almost at ESMO 2016, and that's been published in the New England Journal of Medicine, discussed that there was actually an improvement in the disease-free survival in patients who received sunitinib, almost a 59% 5-year disease-free survival compared to 51% of patients who had placebo. And actually the overall survival, which was an endpoint as well, was 6.8 years on patients who received sunitinib compared to patients who received placebo, which was 5.6 years. And based upon the 24% reduction in risk of recurrence, based upon that data, it received its FDA approval. There were also several other trials that we've seen that have been negative trials. So there was the recent study that was presented last year, the PROTECT clinical trial, looking at pazotinib compared to placebo. where patients initially started off taking pazopanib at 800 milligrams daily, but due to toxicities, the dose was reduced to 600 milligrams compared to placebo. And when you looked at the data, the intent to treat patient population at 600 milligrams seemed to be a negative study. Yet when you looked at the patients, which was I think the first 400 patients who received the 800 milligrams, they actually had a 31% decrease in risk of recurrence. So it was still questionable, but overall the intent to treat data made it a negative study. And then we go back to the ASSURE clinical trial, which Naomi Haas presented several years ago, that compared as a 1-to-1-to-1. It was sorafenib versus sunitinib versus placebo, and based upon tolerability, the doses were reduced of sorafenib as well as sunitinib, and that too was a negative study.